Alright, this is going to be shock part 3. And we're going to talk about classifications of shock. Hypovolemic, obstructive, distributive, and cardiogenic. Hypovolemic shock, very simply, secondary to decrease in the circulating blood volume. Etiologies include hemorrhage, trauma, GI bleeds, other methods of fluid loss, dehydration, excessive diuretic use, GI loss, sweating, burns from fluid shift, or sepsis. Signs and symptoms of hypovolemic shock: altered mental status, diaphoresis, tachycardia, tachypnea, pallor or mottling, thirst, collapsed veins, increased skin turgor, decreased urinary output, and that would be from shunting towards the core, oliguria, concentrated urine, hypotension. Management of hypovolemic shock. Volume resuscitation is the key. Crystalloids, colloids, vasopressors only after volume resuscitation. Whole blood if they're from hemorrhagic. If they have lost this through an artificial means, and examples of this, the artificial means being bleeding, they have also had a loss of red blood cells. Please take that into consideration. Obstructive shock, secondary to impedance of normal blood flow. Etiologies on this are going to be cardiac tamponade, tension pneumothorax, pericarditis, compression of the great vessels, supine hypotension syndrome, PE or pulmonary embolism or aortic dissection. Signs and symptoms mirror those of hypovolemic or cardiogenic shock. Signs and symptoms specific to the etiology is what we are going to be talking about here. Tension pneumothorax and cardiac tamponade, pulmonary embolism, aortic dissection, and the management of it should be specific to the etiology. Very simply, what would be differences between these? And in the tension pneumothorax, we're going to have absent lung sounds. In the cardiac tamponade, if we saw it coming early, closing pulse pressures, 180 over 160 systolic, if we saw it very early, or maybe 110 over 100 closing pulse pressures in the cardiac tamponade. Pulsus paradoxus is another one. Every time the patient takes a deep breath, we have a loss of a pulse. Pulmonary embolism, we should see a VQ or perfusion mismatch. If the patient's lung sounds are clear, if they sound clear on both sides, and I have them on 100% oxygen, very simply, if I have them on 100% here and they're moving adequate air down on their finger, where I'm checking the O2 sat, they should also be at 100%. If I have ample blood supply and pressure, if I'm loading 100% and I'm getting 50%, somewhere in between I have a perfusion mismatch. Aortic dissection. In an aortic dissection, the history will take you there pretty quickly. Tearing sensation to the back. I have to defecate. If the patient tells you that they have to poop, it always raises my brow. Don't let them bear down if they have a dissecting aortic aneurysm. Differences in pulses from the radius to the femoral might also be seen with aortic dissection. Management of obstructive shock, we're going to be very specific to the etiology. Distributive shock, let's go back and talk about those very quickly. Tension pneumothorax, chest decompression. Cardiac tamponade is going to be a pericardial centesis. Pulmonary embolism, if it is not a complete and no chest compressions have been done, thrombolytics may be in order. Aortic dissection is going to be surgical repair. Distributive shock, characterized by decrease in vascular resistance or an increased venous capacity secondary to vasomotor dysfunction. Can be further classified as septic shock, anaphylactic shock, or neurogenic shock. In septic shock, occurs secondary to systemic infection, Predisposing factors is going to be an immunoinsufficiency or non-scanomial infection. We get the baddest bugs out of the hospital. Release of endotoxin by infecting organism causes a vasodilation and an increased cellular cell membrane permeability. Very simply, the vessels go from this to this. It increases permeability due to a breakdown of the actual walls from the battle that's ensuing between your immune system and the endotoxins of the bacteria. Signs and symptoms of septic shock: fever, chills, diaphoresis, petechial rash. A petechial rash is small little hemorrhages that are occurring in the capillary beds, and then pulmonary edema. Pulmonary edema would be we have lost continuity of the capillary alveolar membranes. Management of septic shock: identification and removal of the infection source, fluid therapy, and then vasopressors. The vasopressors of choice are going to be something that work directly on the vessels themselves to squeeze them back down, or an alpha-1, levofed, or norepinephrine. They're the same one, same drug, would be suggestive. Anaphylactic shock: exaggerated systemic response to an allergen, profound vasodilation from degranulation of a mast cell. Third space fluid shifting and bronchospasm. Etiologies on this are going to be food and drug allergies, administration of blood products, and envenomation of some sort. Speed and severity of symptoms vary, can occur over minutes or days. Signs and symptoms of anaphylactic shock: difficulty breathing, bronchospasm, dysphagia, rashes to include urticaria, and flushing of the skin. Management of anaphylactic shock are going to be epinephrine and an antihistamine, generally Benadryl, and epinephrine. Neurogenic shock results from a disruption of sympathetic nervous system secondary to cervical or thoracic spinal injury. Can also occur secondary to severe head injury, migration of spinal anesthesia, and an epidural. Reduction in peripheral vascular resistance causes widespread vasodilation below the level of the insult. If the insult is below the level of T6, thoracic vertebra 6, bradycardia develops as well. Secondary to an unopposed vagal tone. Prevents compensatory tachycardia if this occurs. Signs and symptoms of neurogenic shock: bradycardia if the insult is below T6, hypotension, warm flesh skin. Management of neurogenic shock: fluid administration and vasopressors, and again, if you can identify that it is neurogenic shock, directly talking to the vessels or using an alpha-1 agonist would be the way to go. Cardiogenic shock results from the heart's inability to maintain sufficient cardiac output, often results from myocardial insult, and this would be ischemia secondary to an acute myocardial infarction, trauma or myocardial contusion, a dysrhythmia of some sort, or vascular insufficiency. Left ventricular failure results in pulmonary hypertension and edema. Treatment goal is to restore cardiac output. Signs and symptoms of cardiogenic shock vary with etiology. Very simply, for those of y'all that think I may be crazy at this point, you have two hearts. If you have right heart failure, you're always going to spill into the previous container. So if you have right heart failure, you're going to have peripheral edema in the tissues. So you're going to have cankles, swelling in the feet, and things like this. If you have left heart failure, you're going to have pulmonary edema. Always the previous container. So signs and symptoms of cardiogenic shock: low blood pressure, and this is going to be same as all shock-like symptoms: low blood pressure, diaphoresis, shortness of breath, tachycardia, tachypnea. If they're in left heart failure, they're going to have pulmonary edema. If they're in right heart failure, they're going to have peripheral edema. Management of cardiogenic shock: volume replacement if the patient will take it. Give volume replacement very slowly, especially if they have a large cardiac history. Vasopressors. In the vasopressor sense, dopamine would be a good start. After that, you may consider dobutamine depending on what your patient is presenting with. Inner aortic balloon pump placement, my apologies, which a balloon pump is placed into the aorta and provides counterpulsation. How the counterpulsation works is as the blood is ejected into the aorta, the machine is timed on the diacritic notch of the left ventricular ejection. It does two things. It starts from about here and blows up in two different directions. One, it's going to assist what your heart just had an output of. Two, it's going to provide back perfusion and perfuse the coronary arteries, which the openings of the coronary arteries are at the proximal end of the aorta. Left ventricular assistant devices, if you'll please review and look at the left ventricular assistant that was implanted on the videos. Pacemaker, which would assist the heart's pacemaker sites, sinoatrial atrioventricular node, and then a CABG, or a coronary artery bypass graft, to replumb the piping. This ends part 3. If you have any questions, feel free to contact me. Name's Roy Smith, roy.smith@redlandscc.edu or smithr@emsa.net. Thank you.